My name is Rachel Hunter, and I'm here as a health economist. Now, I know health economists are not the most popular group of researchers there are. We're known as the ones who just talk about money, and that is what I'm here to talk to you today about, is money. But I thought I'd kind of start first of all with how I got here, and it kind of echoes the things that we've been discussing, or were just discussed beforehand, in terms of the challenges that CFS-ME has to overcome, particularly in the near future. So I actually started out in another very unpopular area. I started out as a health manager. And when I was working as a health manager, I worked in both cancer and cardiovascular services, and I worked as a business support officer across the two professions. And I was looking after the money for both of those. And in cancer services, I had this lovely office. It was gorgeous. It was wall to wall of just glass, great big office, great big desk. It was all nicely painted. You'd go in and there was a really nice feel to it. You'd go into cardiovascular services and it was not that same feel. I had literally an old cleaning closet was my office, and I shared it with another person who was working in cardiovascular disease for people, for the indigenous population. So yet another not particularly popular area. And there was a constant struggle with funding, and I really noted this, that in cancer services we had these amazing trust funds, and actually I didn't even really need to do anything within the cancer services one, but in cardiovascular services, where there's an older population, perceived, people are responsible for their own health kind of issue. In that area, there was a lot more of a fight for money, and a lot more of each penny had to be counted, and each treatment had to be thought about in terms of, okay, how do we justify this need? And working in this area, I became very aware of the fact that actually, when it comes to money, sometimes it's not about logic, sometimes it's not about need. It's sometimes about, as we discussed, about the patient voice and about how it is that you make that argument for funding. So that's how I got into health economics, because I felt that that was where I wanted to get into. How do you make that argument that actually these areas need additional funding that's not coming through? So I think that's important when we think about why I'm here today. So yes, I'm going to be talking to you about that horrible area of money, but unfortunately we do need it to push research. And when it comes to then getting treatments into place, when we go through NICE and other HTA processes around the world, so health technology assessment and how we decide what drugs we approve, people like me are going to be the ones who are going to be helping to get that process through and get these drugs approved and make the argument for increasing investment. Now, so this is why I'm here, but obviously we're going to be talking about more the patients here and what the economic impact of chronic fatigue is. So just a very quick thank you, first of all. As Eliana mentioned earlier today, there's the Uramine group, which I've been lucky enough to be part of. And in particular through that, so part of the networking, I managed to get some data from QME and the biobank. So that's Eliana's group in London School of Hygiene. So really showing the networking works. And I'm going to be showing you some very preliminary findings. So nothing official yet, but some ideas of where we're going with that. So thank you again to Uramine and to the group in LSHTM. So I've already said that it's important that we talk about the economic impact. And in particular, why is it that we look at cost of illness studies? And these have become something that, particularly in chronic fatigue syndrome, have become a lot more popular in the last while. So what is it about these, and why do we want to do them? Well, the idea is that, particularly in this area where there's an absence of high-quality treatment or any identified treatment and access to it, that if all of a sudden people receive this treatment they need, then certain costs would go down. So there's this idea that people might be accessing inappropriate healthcare costs. So in many diseases it would be inappropriate inpatient admissions. There's lost productivity to both the individual, but also to carers and to other family members, as we've heard earlier today. And also, there's ways to actually value the financial loss of quality of life. And as we've heard earlier today, there's a massive loss associated with ME and quality of life. So as I said, basically the idea is to put these costs together and say it costs this much for this disease, and if we came up with a new treatment, it would wipe away the costs. Obviously, though, it's not that simple. For example, if there's no treatment, then there's going to be no cost. And particularly if people are feeling like they can't access treatment or they don't want to talk about their disease and they're stepping back, then this actual health and social care costs are going to be quite low. And I thought I'd just show you, so it's not massively clear on here, but this is taken from ME Science, and it's kind of a discussion blog there. And someone, Tired Sam here, has picked up from chronic fatigue syndrome. So this is a paper on chronic fatigue, describes a condition of chronic weakness that cannot be alleviated by rest, and which is associated with lower quality of life and higher healthcare utilisation. And Sam here says, I'd like to see the evidence for this. We're often accused of wasting doctors' time when really, when the reality may well be that some of us are hiding from healthcare service usage as much as possible. And he feels that actually this focus on the extra cost of healthcare may not be true, and also that there's an unmet need here. And when his colleague here explains to him, actually, this economic burden is important, it still makes sometimes Sam feel like we're just a burden on society, we're an extra cost that has to occur. So I think it's important in these instances to remember, particularly with things like productivity, it's not just the cost to society, but it's also the cost to the individual in that they've lost potential earnings as well through lack of treatment for a disease. So I just thought it was important to point out the patient perspective here. So I don't just think about money, I think about patients as well. So what current evidence do we actually have at the moment? Well, as you can probably guess, not many. So for instance, if you were to look at MS, there is about 29 different cost of illness studies that have already been done, 4 of which are in the UK. With ME, we're looking at closer to about 6. Most of them of poor quality, as you'll see soon, and only 2 in the UK. So we don't really have a lot of evidence. And what I'm going to present very quickly for you is a rapid review we did as part of 2020 Health, part of counting the cost with the Optimum Health Clinic Foundation, that started to pull together what evidence we had to actually look at what is the potential cost of illness. So these are the studies that we managed to identify. 2 of them are cost of illness studies, so one very, very small one with 44 patients, and then a larger one with 222. We also pulled some clinical trial data to get an idea of, particularly at baseline, what kind of costs people had. And one of the biggest ones, although as you can see it's getting, well, it's not aged too badly, but there's one here for specialist services, so Colin, and lost earnings associated with specialist services with quite a large group. So they actually used one of the big cohorts from specialist services where they collect a lot of data on them. But you can see as well that they all come from different services, so it's important to take into consideration that obviously these are people who have been recognised and diagnosed with the disease and are receiving whatever treatment is available, as many of you know, probably through mental health trusts. And here we've got people with primary care, so they may have only been recently identified, they may or may not be receiving treatment for the disease, and may have variable, they may be less severe, or they may be more severe because they're not receiving anything. But there's as a result, a variable group of people. So in terms of the actual costs then, so this is this was updating it to 2014-15 costs, and this is per patient per year. And you can see actually, so the healthcare costs are pretty similar across all of the different studies, and they're actually pretty low. And this again speaks to the fact that actually they're not going to be massive because there's no treatment there. If you look at MS, actually the cost per year is about 21,000 per year because there's treatments, there's things for people to access, there's clinics to go to. So as a result, you have a larger healthcare cost if you actually have some treatment available. But this here might be going for lots of tests, it might be being frustrated with the service, or it might be actually having a good GP who then refers them through a pathway to manage their problem. But you can see that as a result, it's not a massive cost. Where the larger costs sit, and what I'm going to be talking more about, is your productivity losses here. And actually, you can see there's a massive range. So one of them granted back in 2003, we've only got a productivity loss of about £2,000. Whereas if we look at Colin, it's closer to £20,000 per year. So there's a lot of variable differences here in terms of what the actual productivity loss is. And to note as well, these massive informal care costs, that actually there's massive implications of lost time at work and other caring for members of the family. But overall, we're looking at a cost of about 20,000, well, 17,000 pounds per person per year, which again, if this healthcare cost was higher, would result in a higher cost, but a lot of it is to do with productivity losses. So overall, if you multiply it, and I've used the prevalence of 0.2% here, there's a wide range of prevalences used, including up to 0.76%, 1 and 2% in some studies. But even using a very conservative, well-researched estimate, you get a healthcare cost per year of 180 million, with informal care costs getting close to the 1 billion mark. So overall, a cost to, and this is just within the UK, of 1.7 billion pounds. We also had a look at benefits, and it looked like there was about 120 million in benefits as well that were being claimed. So some of these studies, as I said, there's pros and cons to them. They come from different populations. They might not be representative, particularly if they're recruited through clinical trials. They're unlikely to be representative of the population as a whole. So as a result, thank you very much, as I said before, to London School of Hygiene and QME and the Biobank. And we managed to get the questionnaires that people complete at the beginning when they provide their samples for 262 people with CFS-ME and 133 healthy controls. So they're all recruited as part of the Biobank. For each of them, the median age of disease onset is about 29 years, and they've had the disease for about 12 years. So these are people who've had it for quite a while. And so the aim is then to use this data and some other estimates we have on employment and benefits to have a look at what the cost is of CFS-ME. And it's particularly important that we have healthy controls here, because a lot of the time all we're having is just an estimate with nothing to compare it with, whereas actually it might be nice to see what would have happened if the disease hadn't happened or if there was treatment available. So this is just some demographics on the sample. And so the median age is 43. And then one of the important things to note is actually, if you look at a lot of the characteristics, the sample is quite similar between the two groups, which when you're doing work like this, you kind of need, because if the groups differ significantly on something, that could be what's driving the difference rather than an actual, it to do with the fact that they've got CFS-ME. So we've got age of about 43, so they're a reasonable age sample. Majority of female. Now there's a star next to that because this is one of the variables where it did differ between the two groups, where there was a larger percentage of women. So overall in the sample, there's more women, but there's even more in the CFS-ME group. And that's not surprising because we know there's a higher prevalence within women. Overall, although the ethnicity looks a little bit different, it's not statistically significant, any of those differences, but it does look like there's a larger white British sample within the CFS-ME if there was to be a difference. In terms of education, there's no actual significant difference, even though it does look like there's a slight skew towards CFS-ME, so more people not completing or not reaching postgraduate studies. So there's a higher percentage of people with postgraduate studies or completing higher education, but that might just be through random chances. There was no significant difference. Also, in terms of numbers of cohabitating children, so 76% of people with CFS-ME have no children versus 64% with healthy controls. Again, it's not statistically significant, but it looks like it might well be higher. The deprivation indices, though, were exactly the same, although that might be to do with sampling in the areas chosen. So as I was saying, they're 29, they've had the disease for 12 years. So there's information for the CFS-ME group on what was happening 6 months before they were diagnosed with the disease. So remember, this could be 12 plus years ago. And for a number of them, well, for 44% of them, they're in full-time employment. But there's also this large percentage, and you'll see this when I get through the next slide, there's a large percentage in full-time education prior to disease onset. And these are people who are about 17, 18, who ended up CFSME. And you'll see what happens when we hit the next slide. But I think it's important to remember that prior to disease onset, over half were in employment and another 20% were in full-time education, and only 3% were sick or disabled. And so this then is one of the key aspects of the finding. So this is hours of work or study per week for CFS versus healthy controls. And I've put statistical significance up there, but it's clear. 16 hours per week on average for CFSME versus 47 for healthy controls. If you also look at the proportion in work, now remembering that before the onset of the disease, 44% were in work, you can see there's a far lower percentage here, particularly compared to the healthy controls. In education, so they were originally in education, it's about the same here as most of them are around their 40s, so likely to have moved on now. But it looks like most of those within CFSME, rather than moving into the workforce, they've ended up in the sick and disabled category. So undergoing years of where they've missed out on employment opportunities. You can also see in terms of benefits, this again is significant, that 65% have benefits in CFSME versus 28% in controls. Just looking at then how that works out for income, so this is zero income up to greater than 50,000, and the dark purple here are your healthy controls, so they're less likely to have lower income, they're skewed more up towards the higher income, whereas with CFSME you actually have over 10% of people, unsurprisingly, with zero income and more skewed down towards this end. So you can see that already that unsurprisingly, due to lower work hours and less likely to be in employment, we have a reduction in income as well. So to actually put a value on that, and this is adjusting for age, sex, cohabitating children, education, deprivation, ethnicity, so it's not due to potential imbalances in these factors, we then start to see this actual difference of what this income and lost employment starts to work out to. So within the model, age and gender in itself had a significant effect, as we know. Unsurprisingly, as you get older, you start to earn more due to extra learning and experience. I will show you the gender gap in a moment and how it plays out between CFSME and not. But as you can see, for CFSME, the average income was £12,000 versus £23,000 for healthy controls, working out to almost £11,000 a year. If you want to multiply that up to a value to the economy, so obviously this is a value to individuals of lost income to the economy, it's looking at almost £1 billion a year in terms of lost productivity costs. So this is the gender imbalance that I thought I'd just highlight as well. So these are the healthy controls here. So females in general are earning a third less than men. But even with the gender imbalance, men with CFSME aren't even earning as much as women are. So we've got a massive imbalance here that perpetuates throughout the disease. And it's quite obvious that there's a loss of earnings here regardless of what factors you want to control for. So we also had a look at benefits, and this is a very, very preliminary, as a lot of it's free text, so it's taken a while to look at. And the majority of claims for healthy controls, so there was 28% of people that were claiming. Most of that was for child benefits, some of it was for council taxes and those things, whereas, as I mentioned before, there was 66% for participants with CFS-ME. And just doing some very quick maths around that, assuming about £100 per week in payments, that works out to about 170 million per year, which, if you think back to what we found from our study with Health 2020, we found a similar amount of about 110 million a year. So it's good that some of these variables are the same. So I thought I'd also highlight some of the other work that's been done, particularly as part of Euromean, so with some of my other colleagues in Italy. And there was a quick discussion about what's the view across Europe and what are some of the diagnostic issues in Europe. And in Italy, they have the problem where it's not recognised at all. So there's a lot of challenges trying to do the research then, particularly if you want to look at cost of illness and identifying the population and giving out questionnaires. But my colleagues in Italy have put a lot of work into identifying people and actually collecting some of this data. So they did a systematic review looking at what cost of illness studies there are. And as mentioned before, there's not a lot of evidence. There needs a lot more work done, particularly in regard to informal care costs, given the massive cost, but some of the challenges around collecting some of the data. In their study with Italian participants, they found 23% were unemployed, and that 55% had an income between 0 and 15,000 euros, so on the lower end of income. So they had very similar findings to what we've found in our study, and that they spend about 210 euros per month on medication and therapy, which again is very similar to the amount being spent in the UK on healthcare services. So overall, it's obvious that there's a significant loss to individuals and to the economy from lost earnings due to CFS-ME. That it's hard to judge healthcare spending because if there's no service available, there's no loss or no reduction in healthcare spending. So the argument for the extra spending to improve healthcare is access to appropriate care, and that some of that then when drug companies and when health economists need to think about the arguments for that, they need to focus on the improved productivity of people and how we measure that and include it. And in general, that there's a lot more work to be done, that again, this is also another under-researched area. And those are the references. Thank you.
Thank you.